Thank you very much for being here, particularly in person, but also welcome to all of those of you who are online. So my name is Dailey. I'm the director of the McGill AMR Center, and I'd like to welcome you to the seminar today, which is really on the special occasion of first our guest, Dr. Mark Miller, but also particularly timed with the World Antimicrobial Awareness Week, or WA. And so many of you may not have heard of this, but the reason why this week does exist is to bring awareness. And I think through Dr. Miller's lecture, you'll certainly appreciate the reason for this need. But also, I just wanted to take a minute or two to use this week as a way to share with you, some of the initiatives that are happening in Canada, and locally, and because you may not be aware, yes, it's something that the WHO and the UN is talking about. But Canada, as of last year, we have a Pan-Canadian Action Plan, which I think we'll hear a little bit about. But with that comes, some very interesting initiatives, including right now the Public Health Agency of Canada attempting to do a pilot project for antimicrobial economic incentives, bringing in, better access to antibiotics that are otherwise not currently available in Canada. CIHR, all of us are, researchers. We require funding for research, are initiating a community-wide survey to develop what the AMR research strategies actually should be. And so there's a survey going on for another few weeks. If you care to give your voice, I think that it'd be great, because CIHR is trying to figure out what should we do. Yesterday, I was just in Toronto. There was an AMR symposium organized to bring people kind of across the country. It was hosted by bioMérieux, in fact, and it was, among other things, just the announcement of a Can AMR Net, which is a very new CIHR-funded 6-year training program. That is the first time we have a training program for AMR. And so the McGill Center here is coordinating the Quebec hub. The idea is really to try to articulate this across from coast to coast, and also across sectors. So not just biomedical, but agricultural, environmental, veterinary health. And then the center, so the McGill AMR Center, we often do not have our activities at the RI, but in fact, this is we were born just a little bit shy of 3 years ago, and the idea was to bring people to work together across the disciplines, across the campuses. And we now, for those of you who may not be familiar, we have support for students and trainees in the basic science and the applied science for ID fellows. We support collaborative research. And really our biggest mandate is try to bring different communities and different people together. And so this seminar here is actually a perfect example. We've been running seminars always in partnership with another center within the McGill ecosystem to bring people who otherwise don't know each other. So today, I had the pleasure of working with my colleague Cedric Yansuni and with the J.D. Maclean Center for Tropical Medicine and Geographic Medicine. And so with that, I'll let you introduce our speaker. Thank you.
Thanks very much, Dao. And thank you very much also to Dr. Miller for giving us something to celebrate with your presence today. Just a few words on why it's pertinent that the Center for Tropical and Geographic Medicine is involved in this AMR Awareness Week and with the AMR Center, because the burden of AMR really is heaviest in low-resource countries. The ASLM and Fleming Foundation performed a survey of hundreds of laboratories in sub-Saharan Africa, and only 1.3% of them have any kind of bacteriology diagnostics. And that's also where the highest number of mortalities and AMR-related deaths are. And so we thought it was very pertinent to team up on this topic during this week. And with that in mind, it's my distinct pleasure to welcome Dr. Mark Miller to us. Like many people in the room and online, so there are about 160 of us registered for this event. I first met Dr. Miller as a trainee and when I was a trainee, and he was a mentor in clinical infectious diseases and in the microbiology lab when I was training. He was always regarded as the benchmark in whatever he did. And I think that's really been manifested in the denouement of his career. Since that time, Dr. Miller has had a truly illustrious and unique career, combining both academic and industry involvement at the highest echelons. During his hospital-based 25-year academic career, Dr. Miller was chairman of 4 different departments in the hospital, with over 70 people. He chaired the clinical infectious diseases department. He chaired the clinical microbiology, the infection control and prevention, as well as infectious diseases research at the Jewish General Hospital. He was a full-time clinician, administrator, and researcher with, at that time, over 150 publications, and co-discoverer of the hypervirulent NAP1 strain of C. difficile that was so important in Montreal 15, 20 years ago for the first time. He must have not liked being promoted, because as soon as he became a full professor, he hightailed it. So about 12 years ago, he took up a new career and a new position as Chief Medical Officer and Executive VP at bioMérieux. He created from scratch there. He wasn't just a new guy. He created new departments that were new to big diagnostics company. Correct me if I'm wrong, but he created the medical affairs department, the public and government affairs department, spearheaded patient value strategies and departments on companion diagnostics. He managed over 140 people with a combined budget of 26 million euros per year. He's really been at the forefront of defining the use of diagnostics to improve patient healthcare, and is really a unique resource for us. Because of all these positions and experience, he's been in a number of global and international bodies in an advisory capacity, and now recently semi-retired from bioMérieux, but we're planning on trying to keep him busy and on scientific advisory boards for several companies and every committee we can muster. We're very happy to have you here today, and thank you for accepting our invitation. So.
Thank you, Cedric, for a very, very kind introduction. Thank you to the AMR Center. Thank you to the Tropical Disease and Geographic Medicine Unit for the invitation. I'm going to start off and tell you that my objective is not to depress you. Unfortunately, I'm a very evidence-based person, and a lot of the evidence that I'm going to show you is very depressing. Unfortunately, one of the reasons, as Dr. Nguyen was saying, for the World AMR Awareness Week is to raise awareness. And that's because awareness really isn't sufficient about AMR, antimicrobial resistance, in the world today. And things are much worse than what we perceive them to be. However, there is hope. There's hope of using increased diagnostics, some vaccines coming along, some novel antibiotics down the pipeline. There is some hope, but I'll show you that we really need to pay attention. So who am I? I think you heard a little bit about it, so I'm not going to belabor it. And essentially, yes, I'm a clinician, infectious disease microbiology, and got the passion for epidemiology when I did my master's here at McGill. And as you heard, I was a clinician at the hospital and at the university, but then I moved into industry. And in industry, really, it's there where I realized, because I traveled so extensively, and bioMérieux, I'll tell you a little bit about them, but because they're all over the world, I realized just how bad AMR is. So bioMérieux is an international company and been around for over 60 years with about 3.7 billion euros in revenue, about 14,000 employees all over the world, and 1,800 employees just dedicated to R&D. Impressive. It's a 100% diagnostics company. And so my life for the past 12 years has been only diagnostics and trying to show the value of diagnostics, which is not easy. They're present in 160 countries, so I extensively traveled, and that's where I really was impressed by how much AMR there is in the world, And 80% of those infectious disease products are related to sepsis or antimicrobial resistance. So AMR and sepsis really was my life for the past 12 years. And diagnostics, was a huge part of that. This is just an example of all the different products, the product lines that we had at bioMérieux just to address antimicrobial resistance. And there's many different sublines in there. We had thousands and thousands of products. And my job was to show the medical value of each of these. So why are we talking about antimicrobial resistance? Well, we're talking about antimicrobial resistance because it's a huge, huge problem. I know you hear all about different medical problems. Breast cancer is a problem. Chronic diseases like diabetes and lung disease are problems, and that's true, they are. But there isn't a single problem like antimicrobial resistance that's going to touch everybody in the world similarly. It is quite unique. It has been called the silent pandemic, unfortunately, because people don't pay enough attention to it and it's in the background all the time. I added my own little caveat here. Whenever I give a presentation on AMR, I call it the silent pandemic without an end, because everybody thinks about COVID or a flu pandemic. And flu pandemics, COVID pandemics, those types of viral pathogen or other pathogen pandemics, they have a beginning, a middle, and an end, usually. That's the way a typical epidemic curve goes. But the AMR pandemic is not like that. Antibiotic resistance is not going away. It is only getting worse, and there is no end in sight. And as you'll see, the main message here is that we need to slow it down so that we can save lives and we can continue to use vaccines and antibiotics to their full efficaciousness without, losing too many lives in the process. So there really is no end in sight. Now, the famous O'Neill report in 2014 came out and really brought attention to AMR for the first time. Why? Not because of all the lives that were being lost, but because Jim O'Neill was an economist. And for the first time, he put a price on AMR. He put a cost on AMR in terms of what it's going to cost the world in terms of budgets and impact on GDP. And unfortunately, as most things in the world, that's when people started to pay attention. Not because we were losing hundreds of thousands at that time, hundreds of thousands of lives per year, but because there was an economic impact. Unfortunately, only a small set of multi-drug resistant organisms were actually included in the O'Neill report, and most people don't realize that. If you read it from cover to cover, you realize that he only covered organisms for which there was economic evidence or economic statistics. And most of the drug-resistant infections in 2014 did not have economic data associated with them, and they were not included in the report. So his estimate of 10 million deaths in 2050 from AMR is going to be an underestimate. It has to be, because he only counted a small subset of organisms. So if you want to actually see what he counted on the left, for those of you who are interested in microbiology, in his report, he included Staph aureus, Klebsiella, E. coli, HIV, tuberculosis, and malaria. He did not include everything on the right side of the graph, which is everything that we're now dealing with in hospitals and in communities that are killing people by the hundreds of thousands, especially things like Acinetobacter, which has become resistant to almost every antibiotic we have in existence. So again, following along the theme that multi-drug resistant organism deaths are greatly underestimated globally, even in the United States, they don't have a good handle on how many deaths there are. This is a great letter to the editor in 2018 suggesting that the CDC statistics, which say every year 23,000 Americans are dying from multi-drug resistant organisms, is a gross underestimate. And when they did a reanalysis of death certificates from hospitals, they estimated conservatively that it was actually 150 to 160,000 deaths per year. That means the CDC is off by 700%. Okay, and this is a realistic conservative estimate of what's going on in the United States. So for people who think that there's good surveillance going on for AMR, there isn't. And the United States is no different. They really don't have a good grasp of how many people are dying of AMR every year. The in-depth research from The Lancet really shook the world in 2021 because they showed that the numbers are much, much worse than what Jim O'Neill predicted. And they showed that there was a huge burden already in the world Their statistics were from 2019 and they published in 2021, but already in 2019, there were 5 million deaths across the world that were related to AMR, and directly attributable to AMR was 1.27 million. So 1.27 million people around the world every year were dying directly of an MDR, multi-drug resistant pathogen, and 5 million people were also dying in addition to that related to MDR infections. When you look, as Dr. Yansuni said, when you look at which countries are the most heavily hit by antibiotic resistance, you'll see that it's always the same low and middle resource countries, regions. There's Africa, there's Asia, and there's Latin America. And unfortunately, those make up the bulk and will continue to make up the bulk for the next century. So the second Lancet report came out in 2024 and tried to look at the trend over 31 years and what they predict for the future based on what they'd already done, a very good methodology. And they showed that although the good news here, deaths from AMR decreased in children under the age of 5, probably because fewer were being hospitalized, the AMR deaths increased over 80% in adults over the age of 70 years old. So the elderly were really and will continue to really bear the brunt of antibiotic resistance for the next century. In gram-negative infections, resistance to carbapenems, which for those of you who don't know, are our last resort of heavy-hitting antibiotics, resistance to carbapenems increased more than any other antibiotic class in this analysis. And regions with the highest AMR mortality in 2050 are estimated to be in low and middle income countries. So there are continuous warnings, and I just chose 2 from this week. One is from Dame Sally Davies, who used to be the chief medical officer in the UK, and is one of the biggest proponents of trying to control AMR. And then another one is an editorial from Science. The warnings continue. Unfortunately, there's insufficient action. Now, in order to understand the threat that AMR poses, it's not just dying from an antibiotic-resistant infection. Our entire modern medicine is built on our ability to fight infectious complications. And if we lose the ability to fight them by not having appropriate antibiotics, there are many parts of our healthcare system that will disintegrate. So increased antibiotic resistance poses a danger for routine medical procedures that we are used to that will not be possible if there's too much antibiotic resistance in the world. Major surgeries will come with an unacceptable infection risk. Organ transplantation, almost all organ transplant recipients get infected at some point post-operatively. Sometimes it's minor, sometimes it's major, but if they become antibiotic resistant, then organ transplantation becomes dangerous. Cancer treatment is almost always associated with a risk of infection, and immunosuppressive therapy, which has become so common these days for all kinds of chronic diseases, will become dangerous if we have too much antibiotic resistance. So all the things that we're used to as regular garden variety, routine medical care will become impossible, if not highly dangerous. And just to show you that this is not a theoretical concern, and I always wonder about whether I should show this picture or not, because these are real babies. In my travels at bioMérieux, I traveled all over the world, and one of the places I went to was a very sad place in Vietnam. This was an intensive care unit for children. They had 2 intensive care units in this hospital for children. One was for neonates and one was for children older than neonates. And 8 out of the 10 beds, 8 out of the 10 children had a sign that you see here above their bed showing which antibiotic-resistant organism they were colonized or infected with. So 80% of the babies were colonized or infected with an antibiotic-resistant pathogen. KP stands for Klebsiella pneumoniae, PS stands for Pseudomonas, and those babies, even under good infection control, the infections are transmitted in the hospital, and many of these babies will die of their antibiotic-resistant infection. This is real, this is present, this is current, this is not theoretical. So the O'Neill report on AMR showed us that the world listens to economic impact, and so a lot of people have started to look at economic impact of AMR. I'm not going to go into these in detail, but there's all kinds of analyses. This was done by Citibank, showing the impact on GDP and the impact on healthcare costs in the world. There are other ones. This is one that looked at just prophylactic surgery and cancer chemotherapy, that if we no longer had good antibiotics, that the number of deaths from cancer chemotherapy and surgery just in the United States would increase by 120,000 different people in infections and 6,000 more deaths per year. There's other reports that came out, one from KPMG and one from RAND, again showing, and they're all consistent. Without going into detail, they're all consistent that the impact on countries, especially low and middle income countries, is tremendously negative. So how has the world reacted? Well, the biggest event that occurred was the national action plans that were generated by the United Nations General Assembly. They met in 2015 and then met again 2 months ago to reinforce the fact that we needed to do something about AMR. And so the concept of national action plans came out that every country should have a national action plan to tackle AMR. And they gave a whole bunch of different ways that countries can follow this. The WHO doesn't do anything of themselves in terms of developing the national action plans. They just give guidelines about how to do it. It's up to the countries to develop it on their own. And those national action plans must contain a governance. They must contain prioritization of activities, costing for the plan, mobilization of resources, and implementation schemes. Now, in every national action plan, you can't read this, that's unfortunate, okay, but there are many different ways that the national action plan can be deployed. And diagnostics, I'll show you in a minute, diagnostics are very important in terms of determining how successful that national action plan will be. Unfortunately, an analysis of countries in 2022, which was already 7 years after the World Health Organization and the UN General Assembly, suggesting that they have national action plans. So 7 years later, they did an analysis of the countries across the world, and they found that very few countries actually have the implementation of a national action plan. So unfortunately, a lot of talk, very little action, and the countries that you would think would be advanced are not. And of course, low and middle income countries were further behind. And it's not just a problem in low and middle income countries. As much as you just heard from Dr. Nguyen about what's being done in Canada, it's not a lot. And unfortunately, even as an independent analysis, the Auditor General's report in 2023 concluded that the Public Health Agency of Canada, Health Canada, the Canadian Food Inspection Agency, and Agriculture and Agri-Food Canada did not do enough to deliver actions to address AMR, to provide comprehensive surveillance, and to preserve the effectiveness of medically important antimicrobials. It's a very daunting, it's a very negative statement, but it's evidence-based. And unfortunately, Canada, like many other countries, has really not stepped up. So in every national action plan, these are the steps that need to be done. Again, they're very tiny, but diagnostics are key in 2 of these. One of these is surveillance, which is number 2, and one of these is individually reducing antibiotics when in patients, when you see patients. So let's do the first one. Surveillance is extremely important, and we are totally and completely dependent on diagnostics for surveillance. Surveillance is the systematic collection and analysis of health data to inform, plan, implement, and evaluate public health practices. All AMR surveillance starts in the microlab. Without a microlab, you can't have AMR surveillance. You don't know what's going on. So everything depends on the use of diagnostics in the microlab. You can't control what you can't measure. And measurement is the first step that leads to control and eventually improvement. If you can't measure something, then you can't understand it. If you don't understand it, you can't control it. And if you can't control it, you then can't measure if you're improving it or not. So everything starts with surveillance, and diagnostics are the absolute cornerstone of surveillance. This is an example of what we would like to see from a country. This is, surveillance by region, by hospital, by type of pathogen that's interactive. Unfortunately, this remains a theoretical concept. There are many companies, including bioMérieux, that try to supply the software to labs to try to do surveillance like this, but national surveillance is still very lacking. And the problem is, and I'm sorry, but this is evidence-based, there is not a single country in the world which has a systematic continuous national AMR surveillance program for the key AMR pathogens. There are some countries that do something this year for Pseudomonas, or they're doing something with the GLASS protocol from the WHO for a couple of bacteremia or bloodstream infection pathogens, but nobody is doing for all the key pathogens in all infections in any country, and that includes the West. It includes the United States and Canada. Surveillance needs political, financial, and scientific support. It is absolutely critical. The problem is that many governments are not funding surveillance sufficiently. They just don't have enough money, and there's limited external funding that's possible. Many countries, and this is a huge problem that we discussed at lunch, many countries are embarrassed by their AMR rates, and they will not allow public disclosure of their rates. Therefore, they're not sharing. The world doesn't understand how bad it is. And they don't understand that we're all in this together, and what affects Vietnam also affects China. What affects China also affects Canada. We're all in this together, and AMR across the globe is something, unfortunately, that we share. And if we share public disclosure, then we'll start to understand what's going on. And there's also insufficient training to many low and middle income countries to assure a sustainable AMR surveillance. You can't just go in and do it once. You have to go in and do a sustainable system. So there are partnerships. There is some good news in all this. There are some partnerships developing to try to establish AMR surveillance and to bolster the lab capacity in these countries so that they can start doing diagnostics, which lead to surveillance, which lead to data capture and understanding what's going on. The Fleming Fund in the United Kingdom is certainly the most advanced and the one that is the most logical and the most likely to succeed. The Fleming Fund was established after the O'Neill report because of the implications. It's a 3 to 5 year program with lots of funding, about 300 million pounds, which is what, a billion Canadian dollars or something now. So it's about 300 million pounds. And it is very specifically placed into low and middle income countries to help them to build AMR surveillance capacity by building lab infrastructure. So they are supporting 25 low and middle income countries across Africa and Asia. Again, why? Because they bear the brunt of AMR right now. To tackle AMR, and they're doing it through a variety of grants and global projects, and everything is to bolster AMR surveillance so that they will make a sustainable system for surveillance for the years to come. Reducing antibiotic use is the second way of using diagnostics, okay, in order to control AMR. We reduce antibiotics in humans essentially by 3 ABCs. The first one is don't use them when you don't need them. So if you have a viral infection, you shouldn't be taking antibiotics because they have absolutely no impact and they will just generate resistance. Use the narrowest spectrum antibiotic and use the antibiotic for the shortest period of time. In order to really accomplish these 3 things, diagnostics has a major role to play in all of these. So how can diagnostics be used to battle antimicrobial resistance? Well, number one, when somebody walks in with a fever, coughing, or stomach pain, is it bacterial or viral? If it's viral, they don't need antibiotics. If it's bacterial, then which bacteria and which of the focused antibiotics do they need? What's the exact etiology or what's the pathogen causing it? What is the resistance profile of that bacterial pathogen? In other words, which antibiotic must I not use? And conversely, what's the susceptibility pattern? Which antibiotic can I use or should I use? And then on the other side, besides the pathogen, it's the host response. Is this person likely to deteriorate and needs high-powered antibiotics, or is this just a minor infection and they have a good host response? They're not on chemotherapy, they're not on radiotherapy, and they can handle their infection. And maybe we can get away with a smaller dose of antibiotics. These are the kinds of questions that diagnostics can try and lead to in order, what's the end result? Decreasing antibiotic use overall. So appropriate diagnostics can reduce antibiotic use. It's very simple. A person comes in with a sore throat or chills or cough or a fever or stomach pain or urine symptoms. If a healthcare provider does not use diagnostics, they wind up overusing antibiotics. The overuse of antibiotics produces resistance. If that same person comes in and the healthcare provider uses an appropriate diagnostic test, they will use fewer antibiotics overall and they will generate less resistance. This seems like such a simple scheme, and yet it's not followed in the majority of cases. Why? Well, the engineers in the room and the biotechnical people say, well, we need better diagnostics. We don't have good diagnostics. We need better technologies. We need to be more technologically advanced. The problem with that argument is that we already have many, many good diagnostic tests out there, but they're not being used. We have rapid strep tests that can tell you whether you have strep pretty reliably in 15 minutes. We have 15 minutes now with COVID. After the COVID pandemic, we now have rapid tests that are pretty good for flu, COVID, and RSV altogether. We have 45-minute tests for instance, somebody coming in with diarrhea. This is from my previous company, where you can, do bacteria, viruses, and parasites in 45 minutes and tell you what you have, so you know exactly how to target antibiotics or not. We have 15-minute respiratory and sore throat tests based on PCR, very highly sensitive, which give you results in 12 to 15 minutes. We have 15-minute malaria tests that are reliable. We've got 15-minute saliva tests for HIV and hepatitis C as an example of what we have out there. We have a lot of tests. So what is the problem? And that's the question that I get repeatedly asked, chief medical officer for a diagnostic company, why aren't the diagnostic tests being used? And the answer is not simple. The answer is multifactorial, and there are many reasons why diagnostics, even the ones we have today, are not being used. And unfortunately, I even used the head office of bioMérieux was in France. I lived in France, and France has a unique situation. Strep tests, rapid strep tests, are free in France. Any physician who wants a rapid strep test goes online and orders boxes of rapid strep tests. They're free for any general practitioner in any clinic, and yet only 10 to 15% of doctors use them. So they're available, they're free, but they're not being used. And the question again comes, why? There's many different reasons. The first one is it's cheaper to treat with antibiotics than to do a test first. And that's for almost every single situation in the world. Whether you're in Thailand or whether you're in Brazil or New York City, it's usually cheaper to just give an antibiotic than to do a test and give an antibiotic or not. The second thing is that healthcare providers feel pressured to provide antibiotics, sometimes by families, sometimes by patients, sometimes by their desire to do good. And it is easier and faster to just write a prescription than it is to spend 20 minutes explaining why you're not writing a prescription for an antibiotic. And I'm sure many of you are patients and you know what it's like to not get something that you're expecting and then have the physician explain to you why they're not doing it. So there's a lot of pressure on healthcare providers in general to give antibiotics. Healthcare providers don't see the societal harm. They don't see the problem of AMR in society. All they do is see you as the patient in front of them. And by not seeing society's harm and only seeing the benefit for the patient in front of you and the benefit of not being sued if something goes wrong and they didn't give you an antibiotic, there's actually a concept in economics, and this is called the principal agent problem, where you're doing something for the good of the immediate situation, so the immediate good, but you're not doing it for the good of the grander scheme. And this is a difficult thing to resolve because there is the greater good for society of not giving an antibiotic, but there's also the greater good of treating infections when they're in front of you. And there's no incentive for healthcare providers to use a diagnostic. They're not incentivized. In some countries, like in Norway, you can't get a prescription for a throat infection unless you have a positive strep test. The doctor performs the test. It goes away to the lab. It's a rapid result. You have your prescription for an antibiotic, which you go to the pharmacy, cannot be filled until they get the result of the lab test showing that it's positive. If it's positive, they release the antibiotic to you. If it's negative, you don't. So there are ways, and in 2024, we can link up the pharmacy and the lab easily. We did worse than that with COVID. You can do that, but there's no incentive right now for doctors outside of certain countries like Norway to be able to use a diagnostic or to incentivize them to use a diagnostic. And they're not penalized for giving too many antibiotics. So giving the wrong antibiotic, giving a broad spectrum antibiotic, generating resistance, there's no penalty. So they just do it. Many diagnostic tests take too long. This is the technical part. Yes, we do have some that take too long and they don't give enough decision. And all the time we were dealing in my industry life with rapid and actionable results. In order to really impact your care on a patient, it has to be rapid and it has to be actionable. So meaning that it has to be within the reasonable amount of time that you're treating the patient, and there has to be sufficient information to you make a decision, not just information for the sake of information. It has to be the type of information that actually changes your management. And diagnostics are not widely available, which is the last problem, especially in low and middle income countries. So if you actually look at another Lancet Commission investigation of diagnostics, they found that 47% of the world's population had little or no access to diagnostics. Most of it was in low and middle income countries or poor, rural, and marginalized communities. Obviously, nobody's going to use a diagnostic if it's not available in that area. And then certainly talking about the National Action Plan, looking at diagnostics and national action plans was kind of even worse. This is from the AMR Industry Alliance, of which, bioMérieux was a member. This is quite a large group of industries trying to promote the battle against AMR. And in this analysis, they looked at 166 countries who self-reported their national action plan. 79 countries had a national action plan for AMR. 34 were in low and middle income countries. Of those 34, 32 had a published national action plan that you could go through. 26 of them included diagnostics in some way, but only 12 of them included diagnostics in a detailed way. So this really showed that the national action plans are not very well evolved, and diagnostics have not made a major impact into the NAPs. So the other part, and I know that Cedric Yansuni wanted me to cover this, and low and middle income countries have their own problems. They have their own problems in terms of diagnostics, which are very unique. The unique problems in low and middle income countries that we don't have in high income countries are that money is scarce. So many of these countries are dependent on third-party funders. Funders like the World Bank, the Gates Foundation, UnitAid, et cetera. These are the kinds of organizations that pay for diagnostics. They also pay for vaccines and treatments in many cases. But these third-party funders are extremely important in these low and middle income countries, and they are responsible for paying for a lot of the diagnostics. Unfortunately, most of these third-party payers today are only paying for diagnostics and other modalities related to TB, HIV, and malaria. And AMR is not in their mandate. We have begged them to increase AMR, their mandate to include AMR. We have begged them to look at the statistics of how many people are dying of AMR and to increase their mandate to include AMR-related diagnostics, therapeutics, and vaccines, and they will not, or they have not, and they do not. So that remains a big problem in low and middle income countries. Low and middle income countries really don't have a different need for diagnostics than we do here. They have a basic need. They need robust, inexpensive, and rapid tests. They are available in the world. They just don't have them there. You don't need, we were asked very specifically, does bioMérieux need to develop special tests for LMICs? No, because the tests that we have today are very good for LMICs. We just need to get them there. And it was the same problem during COVID. We had very good tests for COVID, all the way from rapid, antigen tests, the rapid tests, bedside tests, all the way up to extremely sensitive PCRs. That was not the problem. The problem was getting them into these countries. Many of these countries did not have them in the end because they just didn't get there. Supplying and maintaining diagnostics in a low and middle income country is extremely complicated. It's much more complicated than bringing in a vaccine or a tablet, to treat certain diseases. Why? Because you've got a complex supply chain for the equipment and the reagents. You have to have storage facilities for the reagents that don't reach 45 degrees in the summer. You have to have equipment installation and maintenance in difficult areas. You have to send out service people to sometimes very difficult remote areas. You need a reliable power supply for most of the equipment, which they don't have in many of these countries where the power goes on and off all day. You need to train lab techs, which are not widely available, and there's a change in turnover in staff. You need quality control, which is often lacking, and you need ongoing customer service and troubleshooting. You can't just drop a machine and reagents into a country and walk away. It's not like a pill where you can just leave the pill and say, take it and I'll be back in a month. So can we succeed? It all depends on your definition of success. I wanted to leave on a positive note. So depending on how you define success, we could succeed. We have to accept a few facts. The first fact is we will never eradicate AMR. It's impossible. The best that we can do is slow it, which is good. We can slow it down, we can stunt it, in time for our vaccines, our treatments, our diagnostics to be able to save lives. We can slow down AMR emergence so that, we continue to be on a good level plane. What happens in low and middle income countries affect us all, so we can't ignore the fact that they're heavily hit by AMR and just turn a blind eye. We need to focus on two fronts at the same time, unfortunately. In the hospitals, that's where you see most antibiotic resistance, but it's a small number. And that's because of the massive antibiotic use in hospitals and sicker patients. But most of the antibiotics in the world are not used in hospitals. They're used in the community. And it's been estimated that no matter what country you look at least half of the antibiotics that are given in the community are given for no good reason. Most of them are respiratory infections that are viral and don't need antibiotics. So the bulk of antibiotics are given in the community, but the bulk of resistance is in the hospital. We're going to have to control both of those areas at the same time, which makes this very, very difficult. And the other kind of light in all this is that it's getting easier to do surveillance without going into patients and relying on micro labs for all of their data. There are novel approaches to surveillance which have shown to be very promising, where we can track AMR without enormous cost and effort. One of those is wastewater surveillance. So this has become, since COVID, this has just exploded exponentially. I know it's a very bad analogy to say wastewater explodes, but the field of wastewater surveillance or using wastewater for surveillance has really exploded. And wastewater surveillance has been shown to be successful. And when I'm saying wastewater, I mean it's wastewater from anything and everything. These are people going in and sampling sewers, sampling water treatment areas, sampling the toilets and airplanes and train stations. I mean, sampling any wastewater that you can handle in order to look at what's circulating in the area. And it's been very successful for viral pathogens like COVID, norovirus, rotavirus, et cetera. It's also been very successful for influenza, COVID obviously, and it matches the lab data that they get. But interestingly enough, new wastewater surveillance has been done for antibiotic resistance genes. And this has also been shown to be extremely useful to follow what's going on in the community without having to rely on labs. And it's relatively easy to perform, relatively inexpensive, and it can be done in large numbers every day, every week, as much as you want. So this is a very interesting way of trying to get a hold of surveillance so that we know what we're dealing with. So in summary, AMR is a global problem, and it's really everyone's concern no matter where you live. It really is a silent pandemic without end. It is not going to end in our lifetimes. If AMR continues uncontrolled, there will be personal and economic tragedies involved. Medical system will start to disintegrate, and routine procedures are going to become very risky. Diagnostics are essential for surveillance in order to understand what's going on, and diagnostics are really important on individual patient care. And with that, I wanted to thank you.
Please join me in applause. I will introduce the new members of our panel. So Peter Dailey is online joining us from California. So I met Peter Dailey almost 10 years ago now through the McGill Summer Institute. And I've looked to him ever since when I'm looking for advice from someone who has seen diagnostics from all sides. Dr. Dailey is a microbiologist and an adjunct professor at UC Berkeley School of Public Health. He's an independent consultant for Carbex and Find. These are two important product development partnerships in the AMR space that many of you probably know. Peter has 35 years of experience in infectious diseases, primarily in research and development of molecular diagnostics. And specifically, he's led research and development of over 20 commercialized diagnostics and blood screening assays in the ID space for multiple companies, including Chiron, Roche, and Cepheid. And I'm just going to put in a little plug here that you didn't tell me to do, but I'm adding it anyway. Next summer, Peter, on behalf of CarbX, will be bringing to the McGill Summer Institute a new course on in vitro diagnostic product development bootcamp. and it's called IVD Product Development Bootcamp, making the move from academia and entrepreneur to product development. And so anybody who's interested in the topic, please join us on June 9 to 13. It's going to be a virtual course, and we hope that you'll be numerous in joining. And thank you very much, Peter, for accepting to join us today and bringing your wisdom to us. Next, we have Dr. David Juncker, who is Canada Research Chair in Bioengineering. He's also a professor and chair of the Bioengineering Department here at McGill. David earned a diploma in electronics physics from the Institute of Microtechnology in Neuchâtel in Switzerland. After a year in Japan's National Laboratory for Metrology, he got sick of Japan and came back to Zurich at IBM, where he did his postdoctoral training. And at McGill, his lab focuses on pioneering micro and nano engineering technologies to improve health. His lab does a lot of super exciting stuff. Unfortunately, he's not going to show us videos today because I didn't ask us, but you really should go on his lab's website. They do really neat things. And I thank him for accepting the invitation today to give us a little bit of a developer's perspective as well to some of these important problems. So with no further ado, I think we are ready to take questions in the audience. Please introduce yourself and give us your question for Dr. Miller or anyone on the panel.
All right, Bastien Castanier from the AMR Center and Pharmacology Department at McGill. So my question is, I guess, for a little bit of both of you, do you think your respective field, which is, let's say, ID, clinical, and what's already done in terms of diagnostics, and the people who make new diagnostics, so David Juncker and his colleagues, are they talking enough? Are they working on the right problem? Are they trying to improve the right things, or is there suboptimal discussion going on there?
That's a great question. That's a great question. So the answer is, in many instances, no. They're not working adequately together. I can tell you that when I meet young engineers or bioengineering students or research people in their groups, that the first thing I ask my job at bioMérieux, and my job continues to be, is what medical question are you trying to answer? What unmet medical need are you trying to address? And they continuously tell me how good their technology is. They're ultra sensitive. They're this, they're that, they're rapid. I said, that's fine. I accept that because I'm not the technical person, and I accept what you're saying. Your PCR is better. Your enzyme immunoassay is better. Your test is better. What are you trying to address? And they usually look at me with blank faces. And the reason is because they haven't interacted with clinicians sufficiently. So I can't tell you the other side about whether, they're getting reluctance from the clinician side, but I can tell you that on the technical side, there isn't enough medical input, because the first question they should be asking once they get that, what I call the eureka moment, eureka, I found something, I discovered something, is if you want to bring it to market, is what am I trying to address? What unmet medical need, or what medical need, or what important medical question am I asking here? And that's often lacking. And that's often lacking because of the lack of interaction. So I think that the kind of synergy that the AMR Center is trying to put together between, scientists, chemists, people who are good at the technical side, animal health, human health is very important, because that interaction just fosters innovation.
Okay, thanks. So yeah, I'll maybe add a little bit to that from my perspective. So I mean, Cedric invited me and I accepted, and then I came here and they say, why did Cedric invite me and why did I accept? No, I'm really happy I came. It was a very informative lecture. And so there's certainly something to the fact that it's difficult for us to know exactly what the problems are on the other side, right? But having said that, that's exactly what we're supposed to do in biomedical engineering. We're supposed to take technologies and then try to bridge the gap to meet some demand that can have an impact. And now that's not an easy thing to do, because when, like what we're just thinking about, we just had a discussion before. I mean, we come up with some new, I mean, from a technology perspective, we want to improve the performance metrics. But that's, it's kind of an idea, eureka moment. I mean, we had that idea like for the latest technology 5 years ago, and it looks simple and it worked kind of simply, but we still don't have an actual diagnostic, but that's 5 years of work before we even get to that point where we have something, and so often like that, where we have something that might even be working. And then I think now is actually the time when we really want to engage with what exactly, and that's actually the question I had a bit too, where we want to engage, what we want to use it for. But here, maybe I want to go back exactly what I learned a bit with the AMR and also from my own experience. I mean, and also maybe contrasting a little bit with again, with drugs, is that diagnostics, to develop a diagnostic and bring it to a market, it's a very high risk and very resource intensive effort. And once you're successful, it's actually a very low return on investment kind of business, especially if you want to go to AMR and these things, right? And we contrast that then with drugs, where it's also very high risk, but if you find a drug and it's successful, then you have a very high return on investment. So it's structurally and institutionally much easier. From private sector, it's also much easier because the VCs, you will always find a VC who be excited by your high risk, high potential return. And I mean, we can see that with a lot of the nanoparticle. I mean, LNP is now an exception, but there have been so many billions in nanomedicines which never panned out. And then on the other hand, with diagnostics, it's just so hard. And as we were just hearing too, I think this is where the government have a huge role to play. The market alone, I don't think, is actually very well structured and operational to address this problem. And it's really where government could have a big role in creating these incentives and these structures to help us to do that. So,
thank you. I think this is actually a very good segue to Peter, because Peter, you, although you've worked in industry and you've worked in academia, you're also very active in the product development partnership space, which is, at least theoretically, I'm not supposed to look at you, sorry, which is at least theoretically there to bridge those gaps and to try to enhance translation of exciting technologies. What's been your experience, and what has been done well, and what still is a challenge for the translational PPPs or PDPs?
Bonjour, hello, from UC Berkeley in California. Good to be here, and thank you for the invitation. This idea of understanding the market requirements is essential. A sort of a bad example, what not to do, is a quote that I use in our bootcamp course. It's from a university professor, and he said, quote, "It was the commercial market that caused the project to fail. It was actually a technical success." And that's the wrong attitude. And it's very important in developing diagnostics to understand what the market needs, what your customer needs. And so that's essentially, there are tools available. I'll be a little bit brief here, and that is organizations like the WHO, like FIND and other organizations put up target product profiles and do a lot of work to try to evaluate what are the customer needs and what product developers need to do.
Maybe I can bounce off right away with you've introduced the notion of a target product profile that is meant as a communication tool between the user or funder and the developer. You and I know how difficult it is to hammer out some of these target product profiles, and often I get the feeling that no one is happy with the result. We're not happy, industry is not happy. And I'd like to hear from developers and industry. So Mark, you've been on the industry side, you've seen some of these TPPs. What is the general feeling when you see a target product profile for a given product? And I'm just going to say something like a biomarker diagnostic for fever versus for bacterial versus viral, or anything you can think of.
So I'm going to tell you that from the industry side, the initial gut reaction is frustration and a bit of humor, because the TPPs are always too ambitious, too unrealistic. And when we get together, we say, wow, I don't know who's going to be able to get this. But that's the initial reaction. If you look at the TPP for what it's supposed to be, which is what you said, it's a communication tool, it's a tool. You are not there, once we and other industry, and Peter knows as well, you're not there to answer every line of the TPP. You're there to use the TPP as a map, as a guideline, something to follow along those lines to give you an indication of where you'd like to be. It's impossible for any industry or developer to meet every criteria in a TPP, but the TPP is the roadmap, and so it helps you get from point A to point B. And if you use it that way, then they're very useful. It also tells you that there's been a prioritization. It also tells you that there's been some consensus. So, I mean, they are useful as tools. But if you look at them, as many people do, as this is what I must meet to get a product to market, then you'll be very, very frustrated. That is not what is meant to be.
Peter, did you want to add anything to that from the TPP, a frequent TPP developer point of view? Is that how you understand the TPP as well?
No, that's I thought Mark makes a good point, and a good TPP should have a basically required characteristics and optimal characteristics, and that gives the developers of the TPP to make a distinguishing between what's the minimum requirement and what is optimal. And it's really important in the development of those TPPs to have local users of the diagnostics and the actual users in terms of clinicians and even patients sometimes, and not just the funders and bureaucrats. It's really important to get people that are on the ground who would use the assay.
Thank you. Is there another, is anyone in the audience, this is your chance to talk with, 3 superstars. Is there any question that any of you have? Professor Momar Ndao, chair of the National Reference Center for Parasitology in Canada. Hello, please give your question.
Hi, interesting talk. Anyway, born in a village, I'm still going there in Senegal time to time. As you said, I don't know how we can really get rid of the MR. I think it's impossible. I say that, I agree. Because when people are sick, fever, there is 2 things they think about. Most of the time is malaria, especially in rainy season, and they always have something backup because they don't want to be dying. The other things, of course, is to go to small, they call it dispensaire, and to get the pills. So, but you say something very interesting when you slow down. That is what you said. I don't know if at bioMérieux you have any department for vaccine where you have the diagnosis you focus on. So there is any thought, because even in the malaria, people are doing something at least to find something, because, sometimes you guys find some people not responding to X, Y, all this malaria drug. Anything that bioMérieux is focusing on vaccine that you can combine?
So I just wanted to respond to your first point, which is I focused on diagnostics, but the problem with AMR is much greater, and it has to do with the whole ecosystem of antibiotics. The fact that in many, many countries, you can go to any corner store and get antibiotics as much as you want. I go on vacation in Mexico, and I'm sure you do too. If you walk into a pharmacy in Mexico, aside from the fact they want to sell everybody Viagra, you can go, it's the first thing they ask you. But if you want and you say, I'd like some Cipro, I'd like some Levaquin, all they ask is how much. They have huge bottles of 1,000, 2,000 tablets of Cipro, Levaquin. Now, I don't know what the content is, but some of them contain the actual antibiotics. So you can get that anywhere. So there's access, same thing in almost every country in the world, outside of maybe Canada, the US, and Western Europe. And the other part is obviously animal antibiotics. And I didn't cover that at all. There's a lot of animal antibiotics, more than we use in humans, that are being used in raising animals. And that has to be controlled as well. So there's a whole ecosystem and everything going on. And that's why it'll never disappear. It's being provoked. In terms of vaccines, I think that there was, and I didn't cover vaccines again because I was focusing on diagnostics, but there's a very interesting publication coming out last month from the Lancet also about the role of diagnostics in the role of vaccines in preventing AMR. And unfortunately, I mean, theoretically, yes, vaccines could have an impact, but the problem is that all the vaccines being developed today are not focusing on the high AMR pathogens. The big AMR pathogens that we're worried about are E. coli, Klebsiella, Acinetobacter, Pseudomonas, and those 4 do not have any. There are some exploratory vaccines for E. coli in the pipeline, but for the other 3, there's no vaccines. So for the big pathogens that we're really worried about in terms of multi-drug resistance and extreme drug resistance and total drug resistance, there are no vaccines. There are vaccines for pneumococcus, which will decrease resistance to pneumococcus, et cetera, But unfortunately, vaccines are not going to have a big role to play on our major drug-resistant pathogens for the next whatever, until somebody comes up with some better vaccines.
Thank you. Do you have any comment on fake drugs that really, this is the main problem also in Africa, fake medication. There is a lot of fake drugs that—
fake, counterfeit drugs, yeah. So, as a Westerner, I always thought that counterfeit drugs was a big, I don't know, smoke and mirrors and exaggeration or whatever. And then I started to travel. And I was just overwhelmed by the problem with counterfeit drugs in low and middle income countries. And antibiotics are some of the prime examples. So I will give you a very concrete example. I was in a hospital in Indonesia, and I went to the pharmacy, and the pharmacy had 3 types of ceftriaxone for injection. And I said, why do you carry 3 types of, aside from graft and corruption and whatever, why do you carry 3 types of ceftriaxone? And they said, well, this company is generic and we don't trust it. And so that's for the patients who have no money. This one is from a company that's semi-reputable, and we did some studies, and there's some active drug in there. And so that's the one patients who have money. And this one is the real ceftriaxone from, the non-generic company. And that one we know is potent, and that's for the patients who have money to pay. And that is unfortunately a reality in low and middle income countries. So when I saw that, and I saw that replicated for many other anti-infectives and non-anti-infectives, I realized that counterfeit is, maybe I was slow to learn, but it's a horrible, horrible problem. And underdosing antibiotics because they're counterfeit is one of the major problems for inducing resistance. So I agree.
There was a question in the crowd. Introduce yourself, please. And
Hi, I'm Jesse Pappenberg, Pediatric Infectious Diseases. So I'm wondering about your comment that, I'm sorry, I just walked in because I was at a Quebec Immunization Committee meeting. So the comment about vaccines is, I think, I don't know if vaccines are part of the answer because they will prevent infections with organisms that are high risk for multi-drug resistance, as much as they are that they can change the way we prescribe or the need to prescribe antibiotics. And I'll give 2 examples. One is a recent randomized controlled trial of a long-acting monoclonal antibody preventing RSV infection in young infants. And in a secondary analysis, what they found, well, primary analysis was that it reduces the risk of RSV medically attended disease by 80%. But how does that, how does AMR or how do antibiotics point to that? Is that in the active arm, there were 25% less prescriptions for antibiotics compared to the placebo arm, because, babies with RSV, they present somewhere and maybe their eardrum is red, so somebody will prescribe them amoxicillin, or they have a bronchiolitis and their chest x-ray is not normal, so somebody will prescribe them an antibiotic for that. So I think that there are ways that that vaccines, for instance, in that way, will reduce prescribing of unnecessary antibiotics if you can reduce viral infections. And the second example is our need to prescribe empiric antibiotics for every baby less than 3 months of age who presents with fever. It used to be standard practice. Baby presents with fever under 3 months of age, gets LP, blood cultures, urine cultures, and then start antibiotics and admit them to hospital. But in part because of the reduction of vaccine preventable diseases such as pneumococcus, Haemophilus influenza B, we noticed that the incidence is lower, and you can tailor the use of antibiotics to patients who are at higher risk. And currently our algorithm in children under 1 month of age is really, you can observe without antibiotics in a baby who's had fever if they meet certain low risk criteria. And that's changed because we're in the vaccine era, or the conjugate vaccine era, for pneumococcus and Haemophilus influenza B. So I guess that's my comment, that vaccines maybe are part of the solution in more of an indirect way than necessarily targeting the organisms that are multi-drug resistant.
Yeah, I know, and I was remiss because the second half of the Lancet article says exactly that, which is, and shows the proof, which is exactly what you're saying.
I should have written that article.
Yeah, I know you should have. Which is, I always talk about the direct effect onto the pathogens, but the indirect effect, if you have fewer elderly people admitted with pneumonia, then fewer of them go to the ICU, fewer of them get empiric antibiotics, fewer of them induce, and it's true. But I'm not as impressed with how impactful that is as the article suggested it might be, but we'll see. We'll see.
Yes, so there's a few questions. I'm going to combine them into a theme. So in your presentation, you mentioned, the problem of access, which is multifold, and particularly in LMIC. So the question is, what could be a roadmap in terms of developing or implementing a better diagnostics in low and middle income country? How much of that, what could be the roadmap? What's the role of industry and technology, sort of new technologies? So perhaps both of you or all three of you would comment. I see Peter had his finger.
Peter, do you want to start with that? I guess, can we distill that into what is the role of new technology versus old or versus conventional? Would that be a fair distillation?
Kind of framework, and so roadmap, more broadly speaking, and then specifically, how would technology play?
So one of the things that I think is important is actually developing diagnostics in the countries that have the antimicrobial resistance. And so that's one of the reasons why Cedric talked about our workshop on enabling the ecosystem of diagnostic development throughout the world. And I think it's important that there are local issues that require local diagnostics. A good example, it just came out last week, and it is the African Union report. They did an AMR report voicing African priorities on the AMR pandemic, and they noted that no leading priority pathogen, right? You're probably all familiar with the WHO priority pathogens. They noted that no leading priority pathogen for Africa is ranked higher than medium on the WHO list, and that the needs in Africa are different from those in high-income countries and maybe elsewhere in the world. So I think it's important that local needs are considered. And I think the thing we have to work for and that we want to work for, and one of the things we are with CARB-X is enabling that local development.
Maybe I can add a few words here too. So I think that's a great point of having the potential for local development. And when I think of diagnostics, as for someone coming from the lab on a chip and microfluidics community, I mean, one of the inconvenient truths that many of the community like to ignore is the fact that these lateral flow assays, which are kind of a microfluidic device, to exist for like 30, 40 years. And they still represent the standard technology that is being used for most diagnostic, despite actually their limitations, both in terms of sensitivity, of how early they can detect, and in the fact that they're not really quantitative. But they're very cheap to make in some ways, and so they have this wide prevalence. And so here I think it's something maybe where we need, maybe we need a technological revolution in some way that makes this a next generation technology like we'd had maybe also with genomics, where we had this next generation sequencing that allow us to really think about DNA analysis in a different way. So can we come up with diagnostics, next generation diagnostics after 50 years of lateral flow or 40 years that could take that while still preserving the low cost factor? And because I think, I also heard you that in some cases, these lateral flow assays are there, but they're not even used. But I think there we also need a cultural change in terms of actually to always use them, like brushing your teeth, basically. We do it every day. Well, if these diagnostics become actually much more powerful and more available, I think that could also lead a cultural change. And here I think we're in a good period. We have a revolutionary period with elections in the South. So now is a good time to think about how we can change the world.
So my viewpoint on LMICs is a little bit different, and I love innovation, and I believe that we have to support innovation as much as possible. However, the biggest problem in LMICs today is that they don't have the basics. The basic microbiology tests that are able to detect most infections accurately and with good sensitivity, they just don't have them. So, a hospital in Botswana said to us, we'd like to do a study of blood cultures, okay, to see what the pathogens are. And, bioMérieux, we make blood culture machines, and can we do a clinical study with you? And I go, great. I said, what are they doing right now for blood cultures for bacteremia detection? And the answer is nothing. No blood cultures. Blood culture is a basic test in the West, okay? They're not doing any, believe me, this is not limited to Botswana. So there are many, many hospitals and LMICs and many labs in general, even in the community, that don't do the basic tests that are available everywhere else in the world. So my belief is that, yes, we need to innovate and make things cheaper and better and easier and faster, et cetera. But for most of the LMICs, they need something like the Fleming Fund, which is to basically support their infrastructure and give them basic lab tests and basic micro tests that enable them to understand what's going on with AMR and to treat patients better. And that we're doing a terrible job of doing. And when you have to rely on third parties to come in and inject money, that's not the way it should be.
Just in terms of technology, do they have cell phones in Botswana?
Yes.
So, and so that to me is an illustration how a technological revolution can actually penetrate that. These cell phones were developed as a high tech. The first cell phones were for these businessmen who could carry them on. But as they suddenly became so convenient and so forth, now they're everywhere. And actually, in terms of also diagnostics, the cell phone is a very powerful it's a computer, it has a camera. So this is something I think where we can leverage that as well. And also as an inspiration, maybe how we can change the paradigms. Maybe blood culture was never suitable for them. But if you have something that's so much simpler and so easy, well, this is, of course, this is not something that will be done in a few years. And it's something that has maybe to start in the West so that this technology become so ubiquitous and so versatile and so simple, and that then they can basically on our tailcode surf and then adopt them in there. And because that's maybe a more promising approach than trying to develop it directly for there, which is very, very difficult given the financial structures and incentives.
Please join me in sincerely and warmly thanking all three of our panelists, David Juncker, Peter Dailey, and Mark Miller. Thank you very much to all of you.